Okay. So the central dizziness. Central dizziness, it has two things. One, it may have a lesion, okay, or it may have vascular related problem. Okay. So if there is a lesion where it can be, it should be in the nerves, it will be in the vestibular pathways, or it can be in the brainstem, or it can be in the cerebellum. If there is a lesion in any of these three areas, we are going to have dizziness. It can be called as an imbalance. Why? Because this is nothing to do with your semicircular canal and the connection between the oculomotor system. It is also connected with the cerebellum, because cerebellum is responsible for postural postural decisions. Okay, postural stability. The cerebellum is responsible, and if there is a lesion in that, then it is difficult for the patient to stand. So the patient will say it's a dizziness. Depending on if the patient is having an nystagmus, if they have a spinning um, complaint, we have to check with the other test which we'll be seeing, like ENG, VNG, and we have other postural test which we have to test the vestibular system and the integration of this vestibular system and the spinal reflex, and then we'll see ocular reflex. The next one is vascular related. As we previously saw, there is a blood supply, and if any one is cut, then the hair cells are not going to respond properly. Okay, if they are not going to respond properly on one side, like we saw previously in the unilateral weakness or unilateral loss, the patient will have vertigo and nystagmus. Okay, this is called a central because the problem is starting in the central pathways, not in the peripheral. Peripheral means your end organs, utricles, saccule, semicircular canals, or these are end organs. If there is a problem, we call it as peripheral pathology. If it goes higher end, like in the vestibular nucleus or higher in the brainstem, we call it a central problem. Okay. Then the other one is the vestibular schwannoma. The vestibular schwannoma is kind of a tumor. It's again a lesion. This is slow growing, it is gradual, and it's benign. It is not life threatening. In a position where you have all these, you call the cerebellopontine angle. Okay, you have a place in the brainstem we have called a CPA. Okay, which is cerebellopontine angle. If there is a lesion or tumor at that position, we call this as vestibular schwannoma. Okay. Will this have vertigo? It may have vertigo because the loss is gradual. Okay. This is not sudden attack. The vestibular loss is gradual. When it is gradual and the vestibular system function is not acting properly, but this is gradual, the brain will start adaptation process. Okay, if it is sudden, the brain is in shock, it doesn't know what to do. But if it's happening gradually, then the brain will understand, okay, there is some problem with this or right or left side vestibular system. So we have to start adaptation. If it is gradual, the brain has enough time to adapt itself, so the vestibular symptoms will not be very much apparent. So how do we diagnose this? This will be diagnosed with the help of the imaging techniques. We have to do MRI, we have to do CT scan. Okay. The next one is the superior canal dehiscence, SCD, which means we have the can everyone hear me? Okay. So we have three semicircular canals. So one is the anterior, which is also called as superior. Okay. So if there is a kind of dehiscence, dehiscence means a small opening. Okay. If or the bony part, there is an opening. What happens? This becomes a kind of window. Okay. Just like your oval window, you have your cochlea, right? You have a labyrinth, and in the cochlea, we have two windows, oval window and round window. Why do we call it as window? Because we have only the membranous labyrinth. We have an opening in the, um, we have some kind of a kind of membrane in the cochlea. That's why it is called as window, oval window and round window. This SCD is also called as the third window syndrome. Okay, what happens? We have an opening in the superior canal, because of which the the endolymph behaves differently. It starts taking too much. Okay, which means the movement of the endolymph is very free. Because of that, when there is a loud sound, okay, the effect is seen in the superior canal, till the superior canal. Okay, so the patient will report vertigo, the patient will report oscillopsia. Okay, so how do we know when the patient is coming? If the patient will say, if I have hear a loud sound, I feel dizzy. Okay, I feel like things are moving. So then we will check for the SCD. Again, how will we diagnose SCD? We have to diagnose with the imaging techniques only. Okay, so how do we know with the audiogram? We can also find a superior canal dehiscence with audiogram. Most of us really don't do our bone conduction very sincerely if the AC is normal. Okay, if the AC is normal, we presume that the BC also should be normal. So we don't test below 5 dB. The clear difference between the superior canal dehiscence is that it has enhanced threshold for bone conduction. Okay, that means the airborne gap will be not that much seen when there is a normal hearing, because the threshold is 10 dB. So the patient will say, I'm hearing normal, but the diagnosis really happens when we do BC genuinely. The BC may be in minus 10 dB. Okay, now how much? The 10 dB and minus 10 dB, we have 20 dB airborne gap. So that shows that the patient has superior canal dehiscence. Okay, so with the audiometry also, we can get an idea if the patient is having a superior canal dehiscence. Okay, fine. Is there any doubt regarding the pathologies? Okay, oscillopsia means I'm looking at something, okay, and I'm seeing it clearly. What happens if someone is holding my head and keep shaking it? Okay, so how do you feel? Imagine you fix at something, you see a mobile, and then keep shaking your head and see the mobile. What happens? The image is actually moving, right? So that is oscillopsia. This will happen even if you don't move the head. If there is no head movement, I'm just looking at thing. But if this happens, moving of the image, or the shaking of the image happens because of a loud sound, and this is called as oscillopsia. And oscillopsia is movement of the object, and this is connected, if it's for the loud sound, it is connected with the superior canal dehiscence. Okay, so I got a question like, what really happens in the SCD? Okay, so I repeat, in the semicircular canal, the superior semicircular canal, there is an opening in the bony. It is not a hole. Okay, if it's a hole, then everything will come out, right? So this is not a fistula. Okay, so this is kind of a dehiscence. Opening means it may be thinning also. Okay, so what happens here is, if a sound is presented, okay, if a sound is presented, you have a kind of uh, pressure which is maintained in the endolymph. Okay, so let's take like this. We have cochlea. The cochlear anatomy and physiology we are very familiar with. So we'll go with it first. When the stapes is pushing the oval window, what happens to the round window? It will come out. Why does this happen? To maintain the pressure. Okay. Let's imagine that there is no round window. Okay. Let's imagine there is no round window. What we have is only the oval window. Now, will it be able to push properly? It will be difficult for us to push, right? Because there is no elasticity in the cochlea. If the round window is there again, the oval window movement is very free. Why? Because when we push, we had a space for the endolymph to move. It was not providing a position. If we had two membranes, two round windows, what will happen? The endolymph will move more freely, right? So instead of having two round windows, now we have one round window and we have one dehiscence in the superior semicircular canal. Is it clear?